Okay, so welcome to this session of the Festival of Public Health. Hope you're all enjoying the festival so far. My name's Isla Gemmell. I'm the host of this session. I'm a senior lecturer in epidemiology and statistics on the Masters in Public Health programme here at the University of Manchester. And I've got my co-hosts, Anjana Sahu and Catherine Lewis, who are on hand, both members of our team, and they're on hand to help with any technical issues. So can I remind you, we are voting for our presentations that we liked. So I don't know if we got it in the chat yet. The link.
I'll just pop it in now.
So.
Just go and get the link.
Oh, okay. So the link to the voting, the area where you can vote on your favourite presentation, or you can rate all the presentations, that will be appearing in the chat now, and then we'll post it. We'll put it back in the chat towards the end as well for a reminder for people. So our first presentation today is by Anita Daniels from University of Ghana. And Anita's going to talk to us about improving emergency obstetric referral systems in low and middle income countries, a qualitative study in a tertiary health facility in Ghana. So over to you, Anita.
I'm trying to share my screen. A minute, please. Okay, good morning, afternoon, evening, everybody. I hope you can see my screen well. Yeah, this is Anita Daniels, and I'm presenting on the topic improving emergency obstetric referral systems in low and middle income countries, a qualitative study in a tertiary health facility in Ghana. I'm doing this on behalf of my other colleagues who are also from the University of Ghana Business School. A little background. Globally, it's been said that about 800 women die from pregnancy and childbirth-related complications, with low and middle income countries having about 99% maternal deaths between people or women in their reproductive ages. And as we all know, maternal mortality is still a global issue. So SDG Goal 3 has it to improve the health of all for all ages by 2030. And reducing maternal mortality is also one of its indicators. Timely referrals and access to emergency obstetric care services has been seen to reduce maternal deaths and disabilities. However, many people are not able to access this due to delays from different angles, as espoused by Tedros and Mim 1994. And these delays range from the decision to seek healthcare in the first place to delays in reaching a health facility, and also when one gets to the health facility, how quickly they are able to access these services. And with respect to referral system, second and third delays are what is a major issue. So ensuring timely access to care during emergency cases has been problematic in Ghana. And in 2012, a national referral policy was designed to this effect to make sure that these delays are reduced to the barest minimum. However, achieving that hasn't also been effective. So what's the problem here? Many existing research on referrals relatively focus less on tertiary health facilities. And in Ghana, for instance, there are a few studies that have been conducted. So this study aimed to identify the barriers associated with the referral of emergency cases to a tertiary health facility in Ghana using the National Referral Center, which is Korle Bu Teaching Hospital, as a case study. And unlike other studies in Ghana and other low and middle income countries that mostly focus on providers' perspective, this study's contribution is very vital because it attempts or it tries to examine the lived experiences of not only healthcare professionals, but as well as the patients themselves, as well as relatives of patients. And the idea is to make sure that we get a very comprehensive view on how to improve upon the referral system. So with regards to ethics, the methods, I want to say that this study was reviewed by the Research and Conferences Committee of the University of Ghana Business School, as well as the Institutional Review Board of Korle Bu Teaching Hospitals. All participants were asked to give informed consent prior to the interviews. And of course, we ensured confidentiality in terms of the reports that came after. People were also free to withdraw from it when they wanted to. So we used a qualitative method and adopted the phenomenology based on the social constructivist paradigm, whereby we try to co-construct meaning or knowledge with people by having a very physical close contact with them. So the people who formed as our participants were women who were referred under emergency conditions to the units of the hospital, then relatives of emergency referred patients, as well as healthcare personnel in the obstetric units. But we used purposive sampling to employ or sample key informants, including doctors, midwives, and nurses. We had 34 of that. Then we also purposively sampled women who were referred under emergency conditions. We did this with the guidance of health personnel. And we also had 31, but participation was solely based on how fit they were and their willingness to also partake in our study. Then we used convenience sampling to also recruit 24 relatives of patients who came to visit their wards during visiting hours, and some too we had to arrange with them to interview them at their place of convenience. So we used in-depth interviews, and with the help of interview guys, we also recorded, we used audio recording, and those that did not give us the permission, we had to write them. Then we also had some people to assist us in collecting data, but relatively all interviews lasted between 20 to 35 minutes. So in terms of data analysis, we went by the Brown and Clark 2006 thematic analysis, from where we tried to develop codes through to coming out with transcripts or transcript to support our major themes identified. So what did we find? At the end of the day, looking at the challenges that we were looking at with respect to the referral system, 4 major themes emerged. These were the global themes that we had. With respect to communication barriers in terms of health infrastructure and supply, and also human resource issues. So I'll use the subsequent slides to give us some excerpts from what we find from our respondents. So in terms of poor communication, we had poor communication between referral and receiving facilities, and this was reflected in unannounced emergency referral. So we had a help of personnel telling us that people do call, but those who do not call, they even have their numbers, but maybe they think they might tell them that the place is full. So you hear the siren blowing and an emergency is at your doorstep. This was an account from one of the health professionals. Then also, per the referral system, they are supposed to go with a referral form, which will itemize the details of the patient as well as caregiving before the transfer. But interestingly, most of them went with referral forms all right, but the information contained in them were seen to be inadequate. So we had a help personnel saying that some of them maybe the way they manage the patients. If you get to know the information, we will blame them. So they usually hide them. But those who also manage or give details. Then as part of the communication issues, they also realized that there was poor feedback system, and the referral policy outlines that this should be the end of the referral, whereby the receiving hospital is supposed to give feedback to the referring facility on what happened with the patient, but realized that this was a function that was actually neglected. So we had a health professional saying that unless the referring facility calls to ask for the information about the patient, there's no channel to convey that. No one has time because they think they have overwhelming patients to attend to them, busily giving feedbacks. So these were some excess when it comes to the poor communication between referring and receiving facilities. Then we also have the transportation system. A major sub-themes that were identified included availability of ambulance services, poor management of patients during transit, then lack of professional escorts. Ambulance is actually seen to be the ideal mode of transportation for emergency cases. But what we saw was that most of them didn't come in an ambulance. Some came, but most of them came in commercial vehicles known as taxi. So we took a taxi. This is an account of a patient who was in an emergency situation. We took a taxi. There was no taxi around, so we had to walk towards the police station before securing one. And I was still bleeding. Then poor management of patients during transit. This is also one of the major headache of the health personnel, because they normally come with taxis and private cars. The condition of them gets worsened. They don't come in with required ambulances, which will help stabilize them. So there's an account of a health personnel telling some of the issues they have, the condition that the patients arrive in due to the fact that they didn't use the recommended mode of transportation. Then lack of professional escorts. Per the referral policy, patients are expected to be escorted by health personnel, at least a nurse, to give details of what has been happening to help them continue with care. But there are instances that most of them even went in an ambulance without an escort. And they recounted that most of them usually come with their relatives instead of health personnel. So the other theme was inadequate infrastructure and supplies. And this is one major issue of concern here if we want to deal with the delay three, trying to limit the delays in giving people the needed care when they get to the facility. And one of the major issues in Ghana here, we hear of no bed syndrome. And this was no exception when it came to our study in this National Referral Center. So one health personnel said bed really affects care. So if there's no bed, no admission. So if the hospital calls, they are bringing emergency cases, you just tell them the place is full. And maybe this can also explain why most of them decide not to call and push the patients to them. So inadequate drug supplies and blood banking services. And it was seen as a major headache for house officers in the hospital because some come in bleeding and they are not able to get blood for them. And it must be noted that the hospital from 2011 to 2015 had over 80% of referred cases resulting in maternal mortality. So that goes on to tell us how bad the situation is in terms of emergency cases involving obstetric conditions that go to the unit. So relatives also share frustration about these kind of inadequate supplies. The fact that they admit that they take good care of their patient, just that where the instances where they have to go and get their own medication before the patient is attended to appear to be one of the worry of some of and one of the the relative of patients. So the last theme that we also identified was human resource issues, whereby due to the nature of the work there, some health professionals as well as relatives of patients who were referred there talked about the fact that they think they needed extra help, especially during weekends, because that time I think most of them are off and the pressure is quite serious for them. So a health professional was talking about the fact that if there's a way for them to increase the staff strength for them to attend to emergency cases, it will be helpful because it becomes very tedious. So in conclusion, what we gathered is the fact that even though maternal mortality deaths are high in low and middle income countries, having an effective referral system working is good to help us beat down on the rates, and that there should be initiatives to improve upon the transportation system for emergency obstetric cases to ensure that patients safety and to make sure that while they are being transferred, they also are able to get optimum care during the transfer. And I must say here that over the years, so the government of Ghana has also added on to a number of ambulances to assist in emergency situations. But unfortunately, they are not only dedicated to obstetric emergencies. So we are yet to see how that's going to save the situation. But from the scope of work that we know, the National Ambulance Service Westwick, we know that it may actually not be a full solution to the transportation challenges that we have seen with regards to transporting emergency cases. So communication is very important because they have to, these are two different facilities, and at the tertiary level, we have a lot of complex cases in high volumes coming. So it's always good to let them be on their guard to make sure that they will know what to do in order to receive these cases and do their best for them. So we are saying that communication between facilities should also be enhanced, and a strong collaboration between teaching hospitals and other referring facilities is also needed, because from what we saw, teaching hospitals are autonomous, and most of the public hospitals referring to the teaching hospitals fall under Ghana Health Service, which does not have full control over the operation of teaching hospitals. So sometimes there's even no forum for them to even discuss how bad the situation are when it gets to their end, or to even advance room for improvement on how best they can treat patients before even referring them. And this was seen in why they were even not giving feedbacks to them, because one encountered that there's even no avenue for that. So it's also one of the issues that going forward they have to look at in order to curb these referral issues with respect to delays in getting to the health facility and also getting them attended to on time. Then immediately patients also get to the health facility, we don't expect that there should be supply side barriers also affecting healthcare professionals to give the needed care to them when they arrive. So these bed issues as well as blood banking services should also be looked at so as to help issues save mothers as well as their babies from dying. So I have some few references here, and that's the end of my presentation. Thank you very much.
Thank you very much, Anita. That's very interesting. I wonder if we've got any questions for Anita. We've got a couple of minutes for questions. You can post your question in the chat, or you can ask, if you can unmute and ask. So, Jamal, did you?
Jamal,
Jamal.
yes. Hi. Anita, thank you very much for this very interesting presentation. I just want to know whether you were able to implement any change already. I can't, forgive me if I don't remember exactly when the evaluation took place and the focus group discussions, but from the findings, were you able to implement any changes, or have you already worked on any actions? Thank you.
Okay, I don't know if I got your question right. You are asking if we're able to augment some changes. Or can you kindly come again with a question?
I think
Hello.
Asking is, as a result of the study, have you been able to communicate these findings back to the hospital, and has it been able to make any change to this system to improve it?
Okay, usually we are supposed to send a report to them after the study, and that is in progress. But this is also an avenue to, the other avenue is to do presentations at fora that allow us to share our research findings. So that's also being worked at. But that's basically the idea of conducting this research, to give them that vital information for improvement. Thank you.
Okay, if we've got no other questions for Anita, we can move on to the next presentation, which is Derek's here. Yeah, Derek. I'll just introduce you. We've got Derek Abila. who's going to talk about using demographic and health surveys to understand the burden of risk factors for cervical cancer among women living in East Africa. Derek was here earlier.
Can't see Derek now.
Oh, okay. Well, we can maybe come back to Derek's presentation. So the next one on the schedule is Cherie Powell. So Cherie is going to talk to us about barriers and facilitators to accessing HIV testing outside of maternity services from the viewpoint of women who have tested HIV positive in Northwest England. So, hi, Cherie.
Hello. I'll just get my presentation up so I can share the screen. No. Can you see my screen? Yes, okay, that's great. Hi, my name is Cherie, and I'm just going to inform you of my study's findings about the barriers and facilitators for women testing for HIV in the UK. So the reason why I chose to study women who were diagnosed outside of maternity services is because maternity services are used infrequently over a woman's lifetime, if at all. Women have a high coverage of HIV testing within maternity services, and women's HIV risk continues when maternity services are no longer needed. For my study, it was a qualitative design, and I used semi-structured interviews, purposeful sampling, and framework analysis. And I use these methods because they have been identified as the most appropriate method for HIV-related studies, so past experiences could be contextualized freely. I had four great, fantastic participants. I have realized that some of it has been chopped off. 4 fantastic participants who were diagnosed in varying different times in the year, different years, from different backgrounds, and had different knowledge of HIV. All of them had no risk of HIV themselves. So the reason why I chose to use this topic to study is because women accounted for 24% of acquired HIV in 2018, and they are generally seen as invisible when it comes to HIV care. Women generally have lower HIV testing rates in comparison to males. 70% of missed opportunities to test involved females, which normally happen at GP services or services that are outside of specialized sexual health clinics. 94% of women who tested positive for HIV did not test in the previous 2 years, and women do have high rates of chlamydia and herpes, which help to facilitate HIV, and it is an indicator of a HIV risk. So the literature review I conducted before the study focused on Western and non-Western women, particularly sub-Saharan African groups. And it found that there was a lack of knowledge that was encouraged by societal stigma and healthcare related issues, which were a lot from the clinicians fearing the embarrassment of talking about sexual health and embarrassing their patient by asking them if they wanted to have tests. Instead, they used observational characteristics such as skin color and last names to estimate the risk. So the first theme that arose in my study was healthcare related issues. All the women felt that clinicians' knowledge of HIV outside of specialist sexual health services increased stigma because they weren't up to date with the modern information, especially medication, and understanding that once they're on their medication and with no problems, that they cannot facilitate, they cannot pass that on to other people. Ashley was the only participant to be screened outside of pregnancy services, and that was because she was a teenager at the time when she was diagnosed with HIV, so she was visiting the clinic as and when. Linda missed multiple opportunities to screen in hospital and GP for 2 years before she had a positive diagnosis. And Kelly, Kelly experienced HIV testing discouragement, which ended up being a positive test for her first ever screen. Well, actually her second, because she was in maternity services at that time before that. The second theme was lack of knowledge. The 2 African participants had good knowledge of HIV in comparison to the women who were born in the UK. However, the 2 African participants did have a fear of HIV as they grew up in their home country. They saw how access was removed when people were HIV positive. They couldn't access certain jobs or housing. And if they attended a sexual health clinic or for HIV testing, then it could be shared amongst the community, either from people in the waiting room or the person who was testing them. So they even though they knew about HIV and testing, they feared to have a test. All of the women that were interviewed felt that their HIV risk was low, as they were monogamous, celibate, or had protected sex. The third theme was living with HIV. 3 of the 4 women expressed thoughts of dying post a HIV diagnosis, indicating the use of outdated HIV information, which stemmed from the 1980s campaigns where deaths soon followed a diagnosis and there was no medication at that time. The African women discussed cultural aspects that prevented them from screening for HIV, such as church. Now they are positive. Talking about HIV promotion in a positive light was kind of shunned or quietened. And the African women also expressed some people having to ask their partners to have a HIV screen, which is a deterrent in itself. The fourth theme was support. All of the women felt peer support is vital, especially during a diagnosis, because that person will have the experience and the emotions of what they went through when it came to that point, and they felt that they would provide valuable information at that time instead of medical jargon and information that was kind of forced onto them at that time. Kelly expressed difficulties finding a support group that did not only target Africans or Black women, but once she found a group that was varied, her confidence grew, and she had more of a positive light on her new lifestyle, and all the other women from all the other volunteers also agreed. So coming to discussion, my results, lack of knowledge and healthcare related issues was significant in this study and showed that it was preventing and hindering women from testing for HIV. The African women were offered a HIV test after they developed acute illnesses that could have been fatal as a result of undiagnosed HIV. As I told you before, a woman, she was diagnosed after 2 years of being in and out of hospital and with her GP having investigations. And the other woman, she was diagnosed about 6 to 8 months after being in and out of hospital and with her GP after being unwell for several months before she attended her GP. And 3 of the 4 women actually received a positive result for their first screen. The 2 women, African women, didn't have a routine test for HIV when they were pregnant because they wasn't pregnant in the UK. Living with HIV, all the females felt excluded from HIV health promotion, and they felt there was a lack of dissemination of health motive materials outside of the clinic, of sexual health clinics. They would like to see in more places like A&E and other generic areas of care, just to help people familiarize themselves with HIV and to reduce the stigma of HIV. All the women agree that peer support was vital because the medical support that they were receiving at that time, it initially belittled them and they felt that they lost control of their lives, and they just felt that they felt marginalized when it became, the initial process of being diagnosed and going through certain steps, counseling and other forms of support. So coming on to the recommendation, my first recommendation is practice is to normalize HIV testing as a standard. I've also been a sexual health nurse in a number of clinics myself, and I just feel like everybody needs to be asked if they would like to HIV test, because that provides the opportunity for people to say no. The second is for policymakers to help educate healthcare workers. This could be in like mandatory training in trust-wide, where they could have a small module on HIV, because people who are HIV positive do still use NHS and services that are outside of HIV care. have an opt-out system for A&E admissions, because a lot of the nation use A&E and they could use it as an investigative tool, and so can the GPs, and to increase awareness of HIV to the general public to reduce stigma. And for research is to investigate cultural taboos and stigma within the Black African community. So coming to a conclusion, the women do have a considerable risk of missed opportunities to screen for HIV due to lack of knowledge of either the person or the clinician. Current health promotion can facilitate stigmatizing views of HIV by targeting MSMs and Black Africans alone. And the study demonstrates the need for regular training on HIV to raise the awareness of HIV-related care, risk and transmission. And peer support allows people to acknowledge the positive side of their new lifestyle, thus providing them with the courage to disseminate positive information to others. And yes, I would like to thank Joshua Wharton from George House Trust, Rebecca Pang from Lee Skyline BHA, all the lovely participants, and my supervisor, Professor Pennycutt, for all your support and helping me along during these COVID moments. And that is me, guys. Thank you for listening.
Thanks very much, Cherie. Has anyone got any questions for Cherie? Can I ask, maybe I missed it at the start, you only had 4 participants, is that correct?
Yes. Oh, I don't know how to stop sharing my screen so I can see everybody. I'm on the I won't do anything as long as you can see me. Yes, I only had 4 participants because at the time when I started my study, it was during COVID and a lot of people were at home. A lot of women, parents were at home, so there wasn't much space for privacy. And women are not really targeted when it comes to HIV care or HIV research. There are sometimes spots for them, allocated for them when it comes to HIV study. But women, when I've spoken to them, because they allowed me to come into their peer support group, which was really lovely, they were saying that they never really asked to be a part of something or HIV, and by the time they were aware of it, even if they're informed by their clinician, sometimes it can be too late because a lot of their spots have been taken, and hardly of the the research that was trying to look for in the UK hardly spoke to women. So I wasn't surprised that I didn't really get a lot of people, but I was very thankful for those 4 participants because they gave so much information, so much experience to the study, because they had never really been spoken about their experience leading up to a positive diagnosis, which I feel like a lot of light needs to be shone on, especially for women.
Thanks for that. I think we've got another question from Alicia. Alicia, do you want to ask your question?
It wasn't really a question, it was more a comment. Thank you very much, Cherie, for the presentation. It was just a comment to say that I think your findings probably aren't isolated to testing, and that there are other services that women struggle to access as well. I've got particular concerns about the access that women and groups outside of the kind of traditional MSM might have around accessing things like PrEP. So I think definitely transferable findings. Thank you.
Yes, thank you for that. Thank you. Oh, stop sharing, there it is. Thank you for that.
That's great, Cherie, thanks for that.
Thank you for watching.
And I think Derek's come back into the meeting, into the room. So Derek, if you're ready to give your presentation, we can do that one now.
Okay. Yeah, so let me start my presentation.
Okay, I'll just introduce you. This is Derek Abela. You're going to talk about using demographic and health surveys to understand the burden of risk factors for cervical cancer among women living in East Africa.
Can you enable me share my screen?
You should be. Oh, I might have to allow you to do it again. Sorry, because you've come back into the meeting, which I just. Yeah, I think I need to. Yeah, you should be able to do it now.
Are you able to see my screen?
Yep.
Yeah, so I'll be presenting about work that we have done to understand the burden of risk factors of cervical cancer in East Africa. This is work that I did with colleagues here in Uganda. And I am Derek Kabila, who is presenting on behalf of the team. I'm currently a second year Master of Public Health student at the University of Manchester. So to introduce, cervical cancer is one of the leading causes of morbidity and mortality within East Africa, as well as in other low and middle income countries. And in particular in East Africa, if you look at the cancers that affect women most, cervical cancer is number one compared to the developed world, where breast cancer is usually like the number one cancer that affects primarily only women. And the major driver of this has been HPV infection, as well as other associated risk factors. The incidence in East Africa is quite high at about 40 cases per 100,000, generally in East Africa. And if you look at the incidence rates within all the East African countries are basically 5. And if you look at these countries, the incidences are greater than 40 cases per 100,000 of the population. And currently, if you look at screening, because to control cervical cancer, one of the things that has to be strengthened is screening. Currently, we don't have established population-based cancer screening programs. Most of the programs are ad hoc and isolated within various regions, but there is no established population-based cancer screening program. Last year, the World Health Assembly adopted a strategy whereby cervical cancer came onto the limelight, and WHO proposed that countries work towards eliminating cervical cancer. And the goal of this was to reduce the number of cases of cervical cancer to as low as 4 cases per 100,000. That is, I think, by 2030. And for countries to achieve this, it's important to first of all understand what are the drivers of the burden of cervical cancer. And one of these is to understand what are the risk factors that contribute to this high burden. So from previous literature, it's known that risk factors like tobacco use, obesity or overweight, early sexual debut, early age at first birth, the number of children a woman has, and use of hormonal contraceptives. All these risk factors have been shown to increase the risk of someone developing cervical cancer. So in this study, our interest was to understand what is, apart from the number one cause of risk factor, that is human papillomavirus, what are the other risk factors and what is the burden of these risk factors in the population of East Africa? So to understand this, we would need like a population-based kind of study, but we were excited to know that there exists a public database that has data sets from data collected from population-based surveys. And of note is the DHS program. DHS is basically a demographic and health survey program that collects and analyzes data on population health and disease-specific interests, especially in low and middle-income countries. So as per 2011, there have been over 400 surveys that have been conducted in over 90 countries. And Uganda has participated so far in 6 surveys. So the surveys are of 3 types. We have the demographic and health surveys. We have surveys that are disease specific, for example, the malaria indicator surveys, and also the AIDS indicator surveys. So in this study, we used data from the demographic and health surveys that were conducted in East Africa between 2010 and 2019. These surveys are conducted every 5 years in these countries. So our target population was females aged 15 to 49 years, and we included data sets from countries in East Africa, that is Burundi, Kenya, Rwanda, Tanzania, and Uganda. So the latest data set was from Burundi, that was in 2017, and then the earliest was Kenya, that was in 2014. The risk factors that we considered were basically 6, apart from HPV infection. And these included tobacco smoking. So the exposure was if anyone, that is the woman, has ever used or smoked tobacco. And then we looked at body mass index, whereby a body mass index of greater than 25 kilograms per meter squared was exposure. Then we also looked at age at first sexual intercourse, because from literature it's known that early sexual debut, especially 17 years or earlier, increases your risk of developing breast cancer, cervical cancer. So that's why we chose age at first sexual intercourse of 17 or less as exposure. Then also age at first birth, we considered exposure as having delivered at an age 19 years or earlier. And this is also supported by literature. And then also the number of children, or from the literature, it's shown that women who deliver greater than 2 children have an increased risk of developing cervical cancer in the future. Then also family planning, it's known that people who use hormonal family planning methods have increased chances of developing breast cancer in the future. So from this, these are a total of 6 risk factors, apart from human papillomavirus infection. So from these 5 countries, the pooled number of women from the different countries that were included in these surveys were 93,000. And from all of these countries, more than half of the women were younger than 30 years, and majority lived in the rural areas, and ranged from about 70% to about 80%, depending on the country. So when we pulled all these risk factors, the 6, we wanted to find out what is the proportion of women that has at least one risk factor for cervical cancer. And from this, we found that at least from all the countries, when you pull the data, at least 89% of the women had at least one risk factor for cervical cancer. This graph shows a summary of the proportions of risk factors that women had in each of these countries. So if you look at the first bar for each of the graphs, for each of the bar graphs for the different countries, the first one is for tobacco use. And you find that the levels of tobacco use is generally low in all the 5 countries. But when it comes to issues to do with sexual and reproductive health, majority of the women had early sexual debut, and majority had given birth at an age earlier than 17 years. Had given birth at that age earlier than 19 years. And then also majority of the women had delivered more than 2 children. Then if you look at hormonal contraceptive use, it also varies between the countries. That is the bar that is gray in each of the countries. It's the bar number 6. Yeah, so it varies per country, and it's still also quite low, below 40%. And if you look at obesity also varies between the countries, with the lowest incidence, with the lowest prevalence in Burundi and the highest in Kenya, but still varies between the countries. So if you look at this graph basically summarizes the proportions of risk factors that women have within the different countries. So each bar, the first bar represents women who had none of the risk factors that we had included in our study. You find that if you consider the proportion of, or the number of women that had no risk factor for cervical cancer, the majority were in Kenya, and the list was in Tanzania. But if you look at the heights of the bars, it shows that at least majority of the people had one risk factor in each of the countries. That is showed by the brown bars. So this is a forest plot that basically summarizes the pooled proportion of women who have at least one risk factor. And from this, we see that about 89, if you consider the whole of East Africa, about 89% of the women have at least one risk factor for cervical cancer. This is a busy slide with quite a number of graphs. So from this, we basically wanted to find out what are the demographic characteristics that are associated with the number of risk factors that a woman has. So if you look, there is quite there is a variation between all the 5 countries. If we start with Burundi and look at different age groups. So this was these graphs were basically incidence risk ratios that were generated from a Poisson regression model that was trying to find out what are the factors that are associated with the number of risk factors that a woman has for each of the different countries. So, for example, for age, the reference category for age is 14 to 19 years. The reference category for residence is living in an urban area. And then we also considered wealth index, where we have poorest, poorer, middle, richer, and richest. So the reference category for that was people who are in the poorest category of wealth index. Then we also looked at the education level, those who completed primary, incomplete primary, complete secondary education, incomplete secondary education or higher. So the reference category for education level was having not completed primary education or no education at all. And then also we looked at marital status, and the reference category for marital status was those who have never been in union, and they were compared with those who are currently in union or living with a man, or those who are formerly in union or living with a man. So from this, we see that for most of the countries, that is Burundi, Kenya, Uganda, Rwanda, and Tanzania, women who are 34 to 34 years up to 45 to 49 years, they had a higher likelihood of having more risk factors compared to women who are 15 to 19 years. So if you look at residents for all the countries, but starting with Burundi, we find that women who are living in rural areas are associated with a lesser number of risk factors. That is for Burundi, but this is not the same for countries, for example, like Kenya, where it wasn't significant statistically. But if you look at Tanzania, it also wasn't significant. In Rwanda, still, living in a rural area was associated with a lower number of risk factors. So for Burundi and Rwanda, it was quite significant to say that a woman who stays in a rural area is likely to have less number of risk factors compared to someone living in an urban area. So when you look at wealth index, here in the graphs is indicated as poorer, middle, richer, richest. The reference category is people who are in the poorest wealth index. Yeah. So we see that, for example, in Burundi, those who are in the poorer wealth index were less likely to have, were likely to have lesser numbers of risk factors compared to those who are in the poorest wealth index. But as you move up the wealth index, it becomes non-statistically significant, although it shows that the number of risk factors were increasing with the wealth index. This is classically shown in Kenya, where those who are in the poorer, middle, and richest wealth index were shown to have higher numbers of risk factors compared to those who are in the poorest wealth index. And this is also seen in Uganda, but it wasn't quite significant in Burundi for majority of the wealth index categories. Then the other variable that was of interest was education level. In most of the countries, having an education that is higher than having education irrespective of the level was associated with a lesser number of risk factors to cervical cancer. That is shown in most of the countries, and the magnitude varies depending on the country. Yeah. So overall, from this study, we see that there's a high burden of risk factors for cervical cancer in majority, with majority of the women in East Africa having at least an exposure to one risk factor for cervical cancer. And then these factors vary per country, and the factors that are associated with the numbers of risk factors that a woman has also varies depending on the country. But there were some trends that were similar between countries, but also different within the countries. So this highlights the need to design interventions that reduce exposure of women to these risk factors. And from the variability in the, first of all, in the burden and the factors associated with the number of risk factors, we see that it can't be a one size fits all for interventions that cut across East Africa, because different factors are associated with the number of factors that a woman has varies per country. So that means that there is need to tailor interventions that are specific for the individual countries to ensure that the burden of risk factors is reduced within these countries, that subsequently reduces the incidence rates of cervical cancer. So this underscores the need to tailor the interventions to the country-specific cancer control plans. So these are the references that we used. Thank you.
That's great, Derek. Thank you very much. Clearly, a lot of work going on in that analysis. Has anyone got any questions? I was wondering, so relative to HPV, how do these other risk factors compare in terms of the relationship direct with cervical cancer rates?
Yeah, so when we're reviewing the literature, most of the studies focused on the association between HPV and cervical cancer. Because if you look at, if you take, for example, 100 cases of cervical cancer, you find that 90% are associated with HPV in East Africa. But the other thing of note is that compared to other countries, for example, the high income countries, you find that if you compare the age at incidence of cervical cancer, it is quite different between the low income and middle income countries. So the question is, besides HPV infection, does the interplay between the other risk factors affect, for example, the progression of HPV? But that is still something we cannot answer now, because it raises the question that why is it that these people are having earlier ages at incidence, and it's known that it's HPV, but why is it that it's earlier? And could it be that because of these different risk factors a woman has, could it be that these risk factors are making the progression faster or slower? But this is still something that needs to be studied.
Yeah, that's great. Thanks. Have we got any other questions for Derek? Okay, thank you. Now we'll move back onto the schedule. So our next scheduled presenter is Bello here? I don't think they're here. No. So our next presenter is Jamel Ahmad-Dashi, who is going to talk to us about evaluating the impact of the London coronavirus response cell on service provision and staff in response to UK COVID-19 pandemic, a mixed method approach.
Thank you. Good afternoon, everyone, and thank you for giving me the, oh, sorry, I'm just going to put the full screen first. Okay. All right, so good afternoon, everyone, and thank you for giving me the opportunity to present to you the outcomes of an evaluation carried out at the London Coronavirus Response Cell, also known as the LCRC, between February and September 2020. My name is Jamel Ahmad-Dashi, and I'm a health protection nurse in London, and I prepared this presentation with my colleague Segar Vezhamdani, who works as an epidemiology analyst at the South London Health Protection team. So to give you some context, the LCRC was created and became live on the 11th of February 2020, a month after SARS-CoV-2 was detected in Wuhan, China, and only a few weeks after Sadiq Khan, the mayor of London, declared COVID-19 a major incident, and the WHO a public health emergency of international concern. Our Prime Minister, Boris Johnson, announced the start of the first national lockdown on the 23rd of March 2020, followed by the start of the first national lockdown, followed by the launch of the National Health Service Test and Trace campaign. In August 2020, Matt Hancock, our then Health Secretary of State, announced his plan to scrap Public Health England and create a new public health organization, all this as we were evaluating the LCRC. At the time, staff from the 3 London health protection teams, as well as colleagues from other Public Health England departments, including screening and immunizations, dental, health improvement, and more, were rapidly brought together as a priority to support the LCRC while managing business as usual, as we were starting to struggle with the influx of COVID-19 cases being notification. The LCRC carries the following functions with the aim to provide an acute public health response to COVID-19 pandemic in London, manage COVID-19 related cases, contacts, and outbreak, and relieve the pressure of the 3 distinct health protection teams that were managing other infectious and environmental hazards. The operating model of the LCRC aims to provide a clear leadership structure through strategic oversight, clinical subcell, and key workstream areas such as care homes, education settings, and prisons, amongst others. So our evaluation aimed to identify the LCRC strength and other areas for improvement, consolidate learning and promote what worked well, ultimately to overcome barriers of the LCRC achieving resilience, safety, flexibility, effectiveness, and efficiency. Our methodology included a retrospective quantitative analysis of the clinical cases and incident management system during phase 1, as well as a survey on staff perception and experience of the LCRC, with 167 participants that represent a response rate of 81%. Phase 2 consisted of a focus group discussion with an external facilitator independent to the LCRC. Several potential bias and other limitations were identified, including recall bias, staff availability, and workload, and the continually evolving political context. Areas such as training, capacity, teamwork, communication, and health and well-being were explored as part of the staff survey and helped identify the following 4 themes that were then discussed more in depth during phase 2 of the evaluation. An appreciative inquiry approach was used to explore the last 2 themes on teamwork and strength of the LCLC and its long-term future. For those who are not familiar with the approach, appreciative inquiry focuses on what is working rather than not working, and leads people to think about the future in a positive way and what they would want or need to do to implement change. So although I'm unable to present to you all the evaluation findings due to limited times, I would like to give you an idea of the type of data we were able to collect using 2 of the 6 themes that were explored. As you can see, the analysis of LCLC staff and staff health and well-being in the midst of the pandemic and our public health response show that less than 50% of respondents had the opportunity to take a break during their shift and look after their physical and mental health. And up to 50% experienced fatigue, were worried about making mistakes, and 33% felt overwhelmed by the volume of work. Only 6% said they faced no challenge. With regards to training and keeping up with change, although the majority of people thought they were getting the right level of support and were able to develop new skills while at the LCLC, less than 50% of respondents reported learning about the role through buddying up and shadowing someone more experienced. Participants in the focus group discussion felt training had been somewhat an afterthought. Effective internal communication channels were also identified as a key aspect of the LCLC when supporting staff through change, including continuous change in guidance and standard operating procedures. So what did we do? Well, the first thing we did was to develop an action plan capturing findings of the emerging themes. We created new roles such as training and health and well-being leads, implemented workload and prioritization meetings with our clinical leads, and set up a better system to manage capacity and the rota. We also increased our capacity and resilience, strengthened our strategic focus on complex settings and vulnerabilities, ensuring representation across all staffing group in key work stream areas such as care homes, education, healthcare, homelessness, and prisons. We also strengthened staff support and improved internal communications. Our action plan is ongoing, and we envisage to reevaluate our staff and service in the near future. So, in summary, we were able to bring the 3 London Health Protection team into a unique operating model. The evaluation gave us some time to stop, think, and reflect through uncertainty and continuous change as we were learning more about the virus and its transmission. The evaluation also allowed LCLC staff to engage and provide feedback on our strong but yet imperfect emergency response center. We're still working through the action plan, and themes identified from the evaluation are being considered as we transition to the new UK Health Security Agency. I would like to thank my colleagues who contributed to this presentation and those who dedicated time and energy to this evaluation. Most importantly, I'd like to thank on behalf of the evaluation team, all LCLC staff who participated in the survey and focus group discussions. Thank you very much.
Thank you very much for that presentation. I think it's great to try to sort of assess the views of your staff while you're in the midst of the pandemic and they're all having to deal with it. Has anyone got any questions? I think we got a question from Catherine.
Yeah, I was wondering, sort of the impact, was that something that changed during the course of the pandemic?
By impact, what do you mean?
Well, the impact of the cell, or the, you know, were there any differences throughout the course of the pandemic?
Sorry, I'm trying to really understand whether your question relates to something very specific, or it's just in general.
Just in general, really, yeah. In terms of, you know, the response and the challenges, was that something that changed?
So throughout the pandemic, sorry, I realized actually I didn't put my microphone by, so I hope you were able to hear properly. It did, because of the continuous change, we did have to adapt, you know, all the time, and identify new challenges as well. And it was really complex, but the evaluation findings enabled us to improve the service as we were delivering it as well. And we did identify a significant change with regards to the way we were delivering services, but also the way our staff were you know, working and engaging with different services, like especially the health and well-being activities that we implemented as well. So you know, I hope I answered your question.
Yeah, that's great. Thank you.
Okay, thank you.
I've got a question, if that's okay.
Mm-hmm.
Jamal, a few things. Thank you for your excellent presentation, and thank you as well to all the PHE staff and all those working in public health in responding to this crisis. I think it's, I have to say, it needs more recognition, really. So thank you for everything that you've been doing. And I was just really well, I want to ask you so many things, but I'll focus on just a few questions. One was, did you have, as a health protection team, did you have sort of requests for training, not just for within the team, but also externally? I know we've had requests for training, and where it was, when it was delivered, it was sort of said, as you mentioned as well, an afterthought.
So yes, absolutely. So we work very closely with our colleagues at the local authority as well. So the Director of Public Health and the Public Health team. So in collaboration, and of course with the settings we were supporting and through the pandemic, we ended up developing specific training based on the training, based on each setting really, and deliver that as webinars, for instance, for all our stakeholders. So obviously, as you know, the LCLC was set up rather rapidly, and it's true that initially we really focused on the notifications of cases and find out an effective and efficient way of managing the number of notifications we received. And then moving forward, we were able to engage more with and get our stakeholders to engage more with us as well, in order to develop specific training. So yeah, it took a bit of time, but we eventually got there.
Thank you. And the other thing was, I think you mentioned about, in terms of communication, that it was preferred rather than email communication to have sort of regular huddles. And do you think that sort of working will be carrying on in future?
So what we noticed is that initially we were bombarded by with emails due to so many changes. So you know, on a weekly basis we were getting, I can't even remember how many and can count them, but we were really bombarded with emails on different guidance changes and SOPs, so standard operating procedures change, and briefing notes, and we weren't able to cope with from an individual point of view as well. They were daily collated emails as well with a list of linked to different guidance, and we weren't able to digest all the information we were getting. So eventually we decided to have a weekly all staff meeting where we were able to update our staff on various changes that happened during the previous week, for instance. And it's true that staff reported, that was their preference of communication. I'm not saying that we're not getting any emails at all, but at least we're still able to get a proper update on a weekly basis.
Brilliant. Thank you. Thanks very much.
You're welcome.
Thanks, Jamel. I think we'll move on to our final presentation of this session. So this is Arenes Chinoso and Dominion Area. Sorry if I pronounced your names wrong. And they're going to talk about the effects of substance abuse on mental health and well-being in Edo State, Nigeria.
Okay, warm greeting to everyone. Good afternoon, good morning, good evening. Am I being heard?
Yes, that's great. Are you able to share your slides?
My partner would do that shortly.
Yeah.
Dominion is going to do that shortly.
Okay, there we are.
Okay, so all protocol duly observed. Good afternoon, good morning, good evening to everyone. Thank you very much for this huge platform and opportunity. My name is Arenes Chinoso, and my partner in which we did this together, this photo essay together, is Dominion Area. We are both students of Ambrosali University Medical School here in Edo State, Nigeria, and we are doing this presentation in conjunction with CMDA, Christian American Dental Association, and Precious Gems Charity in the UK. So our key focus is on mental health, but we are narrowing down to our theme, which is the effect of substance abuse on mental health and well-being in Edo State, Nigeria. Next slide, please. So we focused our local community is Edo State, Nigeria. Edo State is one of the few South states in Nigeria. Next slide, please. So, like I said before, our theme for today is the effect of substance abuse on the mental health of citizens of Edo State. And why are we so passionate about mental health? There is no health without mental health. Mental health is a very instrumental part of the well-being of everyone. And according to the World Health Organization, 1 in 4 Nigerians, that's about 50 million people, are suffering from one sort of mental illness or the other. So drug abuse is a very key challenge in this part of Nigeria, in this community where we are. It's a very huge challenge. We see or we find lots of youths, lots of promising people abusing drugs and going down with the effect. So we know drug abuse can trigger or can increase mental illness. So if drug abuse doesn't cause it, it could trigger it. And of course, it could increase the tendencies of someone going down with mental illness. So as mental health advocates, as medical students, and as active volunteers, we are playing our own role to reduce the cost and to ensure that everyone stays healthy mentally. So before we continue with the slide, I'd like to say, viewers, the discretion is advised in this photo essay, and not all pictures here are real. Some we had to recreate it to paint a very clear and great picture of what we are trying to say. And in this part of the world and this part of our country, drug is not legal. It's not legal here yet. So next slide, please. So at this point in time, we would start by, So drug abuse is a leading cause of mental related challenges in Edo State. You can see from this picture, the lady is abusing drug. We all know drug is meant to for our well-being, but when it's been taken more than the acquired dose, it's a lethal dose. So continual drug use leads to addiction. And we know when some of these people get addicted to these drugs, it affects every aspect of their life. There's increase in crime rates in our community due to the abuse of drugs. There's increase in crime rates. There's we realize that the function in their school and where they work has deteriorated due to the abuse of these drugs. And also there's low financial power on this part because they keep lending money, borrowing money, selling properties to get some of this to buy these drugs. Now this is the other one was she was inhaling. This time around it's an intravenous drug use, like she was using it intravenously, and it's becoming popular among the drug abusers. And we also as medical students during our clinical rounds, we see some patients go down with certain clinical diseases like hepatitis and the likes due to sharing of syringe and the rest. So it also affects the general well-being of the health. Next slide, please. And I like to, okay, this is another form of drug abuse, alcohol. We see these persons abusing it, taking it in very large quantities. And alcohol is a very common source of substance abuse in Edo State. Next slide, please. I like to also say in 2018, a report was made by United Nations Office on Drugs and Crime, as we wait for the next slide, the UNODC, and it reviewed that marijuana to be the most consumed by an estimated 10.8% of the population in Nigeria here, which is roughly translates to 10.6 million Nigerians. So the use of marijuana and other substances occurs predominantly amongst the youth population in this environment. And what comes up next before I hand over to my wonderful partner, who has been sharing the slide so far. Most of the time, we as medical students and as mental health advocates, we come across this is a real photograph of an individual with mental related issues. As we see, most times they're often abandoned by their family to roam around the streets, eating all sorts of things around the streets, going down with more and more diseases and infection. And this is a bit of one of the results from abusing of drugs, and that could lead to one form of mental retardation to another. At this point in time, I'll be handing over to my wonderful partner, Dominion Area, as he takes us through the sign of hope and other wonderful aspects of this presentation. Thank you very much.
Okay, thank you very much, So I'll be taking over from here. I guess we've seen the challenges that are looming around the community, my local community, as regards substance abuse, leading to mental related challenges. So let's see, are there probably some reasons or something we can smile about? What are the signs of hope in my local community that we can actually look at and probably be hopeful that this thing can actually be overturned? This is an outreach organized by the Christian Medical and Dental Association. It's organized to a public school, and it was to educate the children on the dangers of drug abuse. There's a local proverb here that says that it's when the fish is still fresh that you can bend it. So hopefully, yeah, we're trying to get them to understand the dangers associated with taking drug abuse, taking drugs and abusing these substances, and hopefully we can reduce the incidence of drug abuse. As written on the slide, early education is very important. Okay, this is a symposium that was organized by the Ampersali University Medical Students Association. It was held to sensitize members of the university. If you recall from one of the slides my colleague spoke on, he said this is predominant amongst the youth population. So hopefully with this symposium, we can get members of the university metropolis to understand the dangers associated with substance abuse. This event was actually held on World Mental Health Day. Okay, what are the features that are built in my environment that promotes mental health and well-being? Okay, this is the Federal Neuropsychiatric Hospital. It's located in the southern part of Edo State, which is Benin City, which also is the state capital. It helps to provide care for the mentally ill. The services have actually helped to reduce the number of mentally challenged individuals roaming the streets. Like you saw the picture earlier of the lady that was just abandoned in the streets. There are various non-governmental organizations that go around, pick up these individuals from the street, take them to a very good hospital, such as the Federal Neuropsychiatric Hospital located in Benin City, and they are well taken care of, and most often they often recover. Okay, this is Ira Specialist Teaching Hospital. The Department of Psychiatry of this teaching hospital, located actually where my medical school is located has actually helped in reducing mental related issues. I know of a case of someone who actually, due to substance abuse, came down with very serious mental challenges. And just with weeks of proper treating and care, is actually better. I saw him some weeks ago and he's doing very fine. So thank you very much for the opportunity.
Thanks. That was really interesting and a nice change in terms of where it was a photo essay rather than an exploration of a research project. So you've given us a really nice overview of the drug use and mental health in Nigeria. Has anyone got any questions? I've got a question. I was just wondering, I can't remember if you talked about it at the start, but whether you're looking at the effect of mental health on drug use, but you can also look at the effect of drug use on mental health, and that it's poor mental health can lead to drug use, or drug use can lead to poor mental health.
Sorry, I didn't get the question.
So the question is about this sort of cyclical nature of it. So whether you're looking at the impact of drug misuse on mental health, or whether you're looking at the impact of mental health that then leads, poor mental health then leads to an increased likelihood of drug.
Okay. Nonso, if you didn't get it, I think I got the question.
Okay, thank you.
Okay. The slide is actually talking about the effects of drug abuse on mental health. We're actually looking at mental health and drug abuse. Thank you very much. I don't know if you are clear.
Yes, no, thanks. I was just wondering if you could take that into that it is a sort of two-way, it goes both ways. And
Yes, it goes both ways. Yes, yeah. Thank you very much. We get it.
Yes. Thank you.
It's like a circle. Yeah, thank you.
Yes, yeah. Anyone else? Oh, has anyone else got any questions? Okay, well, I'll maybe take this opportunity then to thank all the presenters. We've had a very interesting session. Please remember to vote for the presentation. The link to the voting form is in the chat, so you can click on that, and then I think you can rate the presentations. Has anyone got any further questions to any of our presenters? Okay, that was great. Thanks to you all, and I hope you're enjoying the festival so far, and I hope you enjoy the remaining sessions.
Thank you very much. Yeah.
Thank you.
And, from Nigeria. Thank you.
Yeah, we've had such a wide range of presentations from across the globe today. It's brilliant.
I just wanted to ask a question about the recordings. How will we find them? Where will they be stored, or where will they be located? Or?
That's a good question. I think have you been emailing Greg Williams at all? Who's coordinating the conference?
Oh, I haven't, but I can try. And...
Or the Much email address is much@manchester.ac.uk.
Yes. Yeah. Okay.
Email that email address.
Okay then, no problem. I'll do that.
Yeah, you should get a daily digest email, and we embed the videos. So yeah, you should get that very much.
No problem. Thank you.
Okay, thanks everyone.
Thank you, Chair.
Thank you. I hope you all enjoyed this.
Thank you.
It's very interesting.